Thank you all for joining us this afternoon to talk about responding to the White House request for information on national priorities for artificial intelligence. And to the next slide. I just wanted to walk through the outline of our day today. I'll introduce a few topics, and then I'll turn it over to Ed to talk about the MPA process itself. And then we'll dive into what we've identified as the 4 critical areas of artificial intelligence that we want to comment on as an organization. And we are absolutely delighted to have really a blue ribbon panel of experts to help us navigate these very difficult and challenging waters. We have Ed Hafner, who is the current board chair, Matthew Albright, who is currently our vice chair, Denny Brennan, who is a board member from the Massachusetts Health Data Consortium. Very pleased to welcome Dr. Rebecca Angrove from the Patient Advocate Foundation, Christopher Curry from the American Medical Association, Dr. Kevin Larson from Optum, and Daniel Lloyd from America's Health Insurance Plans. So they will help us go through our slide deck, and then at the end we'll wrap up and talk about next steps. So I just wanted to give folks, most of you know a lot about WEDI, but just on the off chance that we have some folks that aren't as familiar with our organization, we were founded way back in 1991 by then Secretary of Health and Human Services, Dr. Lewis Sullivan. And I will mention we had the opportunity to feature Dr. Sullivan on the 100th podcast, the Collective Voice of Health IT podcast, and I would encourage you to listen to that, a fascinating discussion that he had with our own Michael McNutt. So we were named in the HIPAA legislation as an advisor to HHS, and we continue to have a very solid working relationship with the Centers for Medicare and Medicaid Services, the Office for Civil Rights, and the Office National Coordinator for Health IT. We are a multi-stakeholder membership organization. We really drive much of our work through our 18 work groups and task groups. And if you have the opportunity, go to the website, look at all of the work groups that we have available, and reach out to our own Samantha Hovey if you're interested in joining. And I will remind folks that you join as an organization, so anybody in your organization is also eligible to participate on these work groups. So feel free to push this information out to your colleagues. And as you all know, our roles are to convene, to collaborate, to educate, and ultimately to influence. And that's exactly why we're here today. So next slide. So let me turn it over to our board chair, Ed Hafner, to discuss the MPA process.
Hey, thank you, Rob. And notice we have a lot of new people on the call, so welcome to our WEDI MPA process. So I'll give you a little background on what it's all about. As Rob mentioned, we are a named advisor of Health and Human Services, and we did have an older process called the PAG process, or the Policy Advisory Group process. It was very formal. It was in person for the most part. You were given cards for each organization to raise their hands to vote. It was pretty hard to spin up, and it was, did encourage a ton of conversation. The policy committee reviewed that process, and particularly in COVID times, felt a virtual approach might be better. It would be encouraging people to participate. It'd be easier to spin up. And so they went ahead and created a group called the Member Policy Advisory Group. And Nancy Spector and Bob Bowman both were very active in that process, and they're here today. So thank you, guys. The MPA process is here to solicit WEDI members on about things like topical issues, public and private sector proposals, government regulations, or RFIs like today. where we'll go ahead and sometimes just do it by surveys or interviews, but particularly virtual events is what we've been going after. We've had at least 3 so far this year, maybe 4, focused on interoperability and attachments and fire prior authorization proposed rules. It's very, very interactive. We encourage you to raise your hand and to speak. We want to learn from you. If you want to learn from us, awesome, but we want to hear your voice for sure. Please also feel comfortable in posting in the chat area as well. So that would be another way if you're just a little shy. We're very friendly. It's okay to create a dissenting opinion. Just do it in a very, how do I say, a way in which everybody is working together in a positive way. I'd like to let you know that we will be developing our comments from this process. It's very, very valuable to hear your voice. And we are a unique group of stakeholders, like Rob had mentioned, and having that unique mix is very, very important for Health and Human Services to hear our collective voice. So Rob, back to you.
Great. Next slide. So again, this event was triggered by the publication of a request for information put out by the White House Office of Science and Technology Policy entitled National Priorities for Artificial Intelligence. Obviously, the RFI goes into a lot of issues that go beyond healthcare, but we're going to obviously focus our attention today on healthcare. The comments are due to the government by July 7th. So again, this is really a good opportunity for us to hear from you and for you to share your views. So there's no timeline for government action, but if you're reading the popular press, AI is top of mind for policymakers. So I expect they will want to move faster rather than sooner on some of these key issues. And healthcare is right at the center of the AI discussion. So I think very timely for us to have this event. And next slide. So as Ed said, there are some opportunities for you to participate. You can raise your hand to make a comment, and we ask you to please keep your comments brief because we've got a lot of material to go through. But a very popular way of sharing information, asking questions, making a comment is by using the chat feature. Just know that we do capture the chat. So if you make a comment, we're able to keep that and review it and potentially incorporate it into our comment letter after the event. And as always with the WEDI events, the slides and recording will be emailed to all the participants after the event. Next slide. So I think with that, and as Stanley says in the chat, Congress is also looking at this issue. In fact, it's on the homepage of CNN.com that Senate Majority Leader Schumer has AI on his agenda. And so, yeah, very, very important. And Janice says, so too the Federal Trade Commission. Pretty much everybody, absolutely right. So just to run through the purpose of the RFI as put out by the White House, they state the Biden-Harris administration is developing a national artificial intelligence strategy that will chart a path for the United States to harness the benefits and mitigate the risks of AI. This strategy will build on the actions that the federal government has already taken to responsibly advance the development and use of AI. To inform this strategy, OSTP requests public comments to help update U.S. national priorities and future actions on AI. Next slide. And the background that they include in the RFI includes the administration is undertaking a process to ensure a cohesive and comprehensive approach to AI-related risks and opportunities. By developing a strategy, the government will provide a whole of society approach to AI. The strategy will pay particular attention to recent and projected advances in AI to make sure that the United States is responsive to the latest opportunities and challenges. Through this RFI, they seek information about AI and associated actions related to AI that could inform the development of a national AI strategy. And for those that have read the AI RFI, it is very expansive in its questions. So again, it's not specific to healthcare, but healthcare is referenced in the RFI. We feel it's important for us to weigh in on these national priorities. So next slide. So we'd ask just one poll question here, and just to gauge your level of knowledge on AI and its use in healthcare. So we'll take a second. Michael, can we do that?
Sorry, Rob, I'm going to have to enter these into the poll.
Okay. Maybe we'll have, would it be easier, Michael, to do a show of hands for this one? And again, it just gives us a gauge.
It'll take me another minute. It'll take me 30
Okay.
seconds.
Okay, great. And while Michael's doing that, I'll remind, in particular, I'll have Ed help as a timekeeper to make sure we're moving through the material, and Ed to remind me to speed up if we're getting bogged down a little bit.
I'll do my best, Rob. Thanks.
Yep. Okay, great. Thank you, Michael. So you're able to vote anonymously on this.
Folks, feel free to answer just number one.
Keep it open a couple more seconds. So it looks like most folks have some knowledge of AI. So that's going to make our discussion today a little bit easier. So thank you for sharing that. I think we can close the poll and move to our next slide. And with that, I'm pleased to turn the podium over to Matthew Albright, again, WEDI Vice Chair from Zealous Payments. So thank you, Matthew.
Thank you, Robert. And it looks like almost everybody's got at least a little bit of sense of AI. I think we've all been given a crash course. You've opened any newspaper or journals in the last 6 months. So what I'll do is I'll just give you a low-tech version of what the two things that look like they're going on right now in AI. First, we have what I'll call, and this is non-tech language, right? Humanly programmed AI. This has been around for a while, really taking off now, right? In terms of helping with mundane tasks like opening files, copying and pasting, extracting data, recognizing patterns. It's analogous, right, to when robots took over our factories, programmed to drill in a screw or solder a steam. These have become very smart, and the only reason they might mess up is because of how they were programmed, humanly programmed, right? That is, if you put garbage in, then you'll get garbage out. The second thing going on is what they're calling deep machine learning, which is a revolution, really, that many of the smartest people in the world thought would take another 50 years or maybe never to happen. Deep machine learning is based on layered neural networks. This is what they call generative AI. It's a subsection of deep machine learning. Layered neural networks, fancy way of saying that it's an artificial human brain that learns like a human by combing through gobs of data. Subsection of deep machine learning is what they call generative AI, and that includes the open AI that we've heard so much about. So like the human brain, however, deep machine learning can also pass on inaccurate information or go into weird, sometimes dark places called hallucinations, like falling in love or wanting to take over the world. The most dangerous element that people are talking about in deep machine learning, the part that has the regulators and many smart people worried, even the creators, is that we're not always certain how the AI, the deep machine learning AI, arrives at some conclusions. Even the AI itself sometimes doesn't know how it arrived. In other words, just like a human, say my 16-year-old daughter, we don't know what these AIs are thinking when they say the things they do. Last thing about the deep machine learning AI is, as we know, it's an open source code. Open AI is open source, which means that in a sense, the chickens are already out of the hen house, right? People can put together programs using these deep machine learning in their backyards, as it were, or in their sheds or on their computers. And with that, I'll turn it back to you, Robert. I think I'm turning it back to Robert.
Yeah, thank you, Matthew.
I'm keeping to time.
No, and Heather Manson's in the chat. Wait, there's much more than programming in AI errors and biases. Very, very good point. And then Janice says many deep learning systems, models, algorithms are not open source. Very important point. Thank you, Janice. So I think we can move to the next slide. And so what we want to do is turn it over to Dr. Rebecca Angrove to really talk about AI from the patient perspective, but also she was very kind to share the data that they have collected through their surveys, and that should give us a good sense of how patients view AI. So with that, I'll turn it over to Dr. Angrove.
Thank you so much. Great setup, and so happy to be part of this group today. Patient Advocate Foundation, we work with patients to help them with their access and affordability challenges. Through the course of that work, we serve about 180,000 patients a year across the United States. And then with those patients that we serve, we also do a lot of survey work, insight gathering, and other research and data aligned projects via the Patient Insight Institute. So you can go to our website to learn a little bit more. I won't take up the time here. But I did want to share some of the results that we are seeing when we talk to patients about this topic, because this is something that's also of great interest to patients that are accessing and utilizing healthcare systems. You can go ahead and go to the next slide. So we recently launched a survey of patients, and I'll give you the highlights. I know everybody will have access to these slides to kind of dive a little bit deeper into them. Over half of the patients said that they know AI is being used in healthcare. The interesting part of this data is that only 12% said that it's being used in their healthcare, which is kind of a little bit kind of like, it's not happening to me, but I know it's happening out there. And so what we know from this data point is that patients are really not informed about how and where AI is being utilized within the healthcare system and in their care. But they're hearing the buzzings that it is happening. And then there's a lot of variation around how biased patients feel AI is. Some feel like having AI involved is going to increase bias. Some feel that having it is going to have their healthcare and decisions and treatments be more objective. So again, a wide kind of range of responses and feelings around AI when we talk about bias, combining either just the provider recommending treatments or provider plus AI assist. You can go ahead and go to the next slide. The majority of patients said that they were comfortable with some sort of AI being utilized in their healthcare experience. And when we asked them, okay, which ones are you comfortable with? This is the array that we found. Flagging clinical and medical errors, it was the most, but it's still only 60%. So again, I think it really speaks to different people, depending on their exposure, their understanding, or how these things are being communicated and the use of AI in their healthcare. I think it really speaks to just a lot of differences and variation in all of those different pieces, both from how it's communicated to how it's actually working within healthcare. Not surprising, virtual nursing assistants and diagnosis were at the bottom. So again, patients don't want high tech to replace high touch. And I think those are places where patients really value having that, human interaction. And we can discuss in conversations and or chat any and all of these results as well. Go ahead and go to the next slide. We also asked if patients strongly or agree or strongly agree with some different statements. And so if you look to the right, those that have kind of the yellow outlined bubbles, those are perceptions where the statements where the respondents trusted humans more, right? So kind of human-centric, AI doesn't understand me and my goals and my needs. I'm not going to get personalized care, using AI, so it's not going to take my unique consideration or condition into consideration, just a preference for human care versus AI-informed care. And then the ones on the left side of your screen with the green are really kind of the opposite. So those statements that really position AI as more of a positive or supportive tool. So again, being valuable to make treatment recommendations, making diagnosis. And then there's some concern that AI is going to increase the cost of care, which I think is a whole nother conversation. And this idea that AI is okay as long as there's still humans involved and it's supporting human decision making. So some interesting things. Again, none of these were off the chart, which I think really speaks to the fact that there's a lot of mixed feelings, mixed messaging, and not a strong understanding within the patient community about how, when, and where these technologies are being implemented and used within the healthcare ecosystem broadly and specifically within a patient's care journey. So you can go to the next slide. And really, I put this slide in here to just remind everybody, but specifically from the patient perspective, that the benefits of AI, so those either developing them and or deploying them, should align with the goals of patients, right? So we're all here to do the same thing. We want to increase trust, improve outcomes, and reduce cost. In any way we can get to that end goal is going to make healthcare better and make patients happier. And then a few, if you go to the next slide, just a few perceived challenges. And again, I know within this group, none of this is going to be surprising, but these really popped in our survey and our work with patients is really the concern over increased cost. Healthcare is already expensive, and what is the implications for specifically patient out-of-pocket costs going to be when we're looking at these kind of new high-tech ways to deliver healthcare, and that cost concern is a big one for patients. The widening disparities is another one. So who is going to have access to these more sophisticated technologies, especially if they do have the potential to improve outcomes? And then also by having disparity around access, you're going to have disparity around outcomes. There's also really concerns around loss of personal connection with a provider, right? That idea that high tech is going to replace high touch. Patients are seeking out healthcare at a time when they are vulnerable, they're not feeling well, and over and over, no matter how you ask the question, when patients are seeking care, they really do value relationships and trust. So always thinking about how technology can be supportive of that and not replacing it. And similarly, making sure that there is still personalized care and there is some autonomy of choices, both from the patient side as well as the provider side. And that's a real concern that these algorithms, these AI bots, that somehow they're going to take over this personalized care, this art of medicine that is being delivered by a provider. And so those are concerns that need to be addressed in real time within the technologies, but also just in communicating and educating the public around what's being done. Biased outputs, we will get into that later. Bias in algorithms and the technology is always a concern. We talked about that black box algorithm, right? Like, we don't know how some of these technologies are getting to that end point. So how do you describe to a patient why this is the most effective treatment, or how you came to a diagnosis? And I think that's really concerning for patients as well. And I'll end with the last one being a sci-fi fan. I think a lot of these decisions or these perceptions are still driven by this idea that sci-fi, you think AI and you think these futuristic, scary sci-fi movies. You still, when you Google stock photos of AI, you get some of those images. And I think we have to remember that patients are members of the public that are consuming mass media. And so when they hear that decisions are being made by AI, or is it being integrated into their care, their brain goes to those futuristic, scary scenarios. So again, opportunities and challenges related to education around what these technologies really are. And then my last slide really is just kind of a call to action around what patients need to know, and I've touched on these already. We just need to do a better job of communicating. I think some of these policy initiatives is a way that the government is trying to get ahead of it. But when you think about what patients really need to know, too much detail can be really hard. They don't need to know all of the details about how these technologies have been developed, but they do need to know where they're being used. If there's evidence of effectiveness, and on the opposite side of that, if there's evidence of bias or challenges with utilizing the technologies, and then how providers are still being involved in their care. So I went through a lot of stuff in a small amount of time, as I was tasked to do, but at some point would love to have conversations around any of these points.
And thank you, Dr. Angrove. And we've got some questions, but I just wanted to let folks know we do plan to reference HAL, the computer from 2001, A Space Odyssey, in our comment letter. But Janice asks, do we know how many of the patients that were involved in your survey were aware of how AI works, or aware of how many of their providers are using it, and do they understand how it works and what it means to get the results they get, and how to evaluate them? So any sense from your discussions with your constituents, Dr. Angrove, about how familiar are they with the use of AI in healthcare?
Yeah, so that first slide, or one of the early slides, talked about, about 12% of our patients said that AI was being used, but we were pretty sure that that's a higher number. We did not test people's perception versus reality. We just didn't have the ability to do that. But when we asked people if they were knowledgeable, about a quarter of them said that they had some knowledge of AI. About another third said that they'd heard before but didn't really know a lot. And so I think similar to the poll that we took in this space, even those in this space that we I think assume have some level of knowledge, I think we overestimate patients' true understanding of the technologies that's being deployed, and specifically how within their own care it is being utilized. So good question.
Good. And I see Ellen has raised her hand. Michael, if you can unmute her.
Hey, there I am. I put it in the chat too. This is really interesting to me, because I guess patients don't realize that if they've ever been subjected to medical necessity review, those are using clinical guidelines that have always used AI to be written up. I mean, it's not the fancy generative AI we have now, but it's all about analytics.
Excellent point.
Yes, such a great point, Alan.
And just see a couple more comments in the chat. I wanted to thanks Stanley for saying a very important distinction: AI as an add-on tool versus being dependent on AI. I think that's the message, Dr. Angrove, that I got from your survey, that if it's used as a helpful aid, and as you say, it's not replacing the high touch. I think that's certainly a point stressed in the survey. And let's see, we've got Ellen saying loss of autonomy over personalized care is interesting, since AI is at the core of precision or personalized medicine. Yeah, especially, where health plans are running algorithms to find out, who needs to have certain tests, and they reach out either to the provider or directly to the patient. There's all kinds of opportunities to use this. And then back to the survey, Heather says, I guess that a lot has to do with how you ask the question. I think very important. And then, yeah, James Cameron has a lot to answer for, absolutely. And Ridley Scott as well, I'd add that. And looking through, I think we can move on. So great comments in the chat. Thank you again, Dr. Angrove, for sharing that perspective. And again, to our facilitators, feel free to raise your hand to weigh in at any point. And so we can move to the next slide. So what we want to do is focus on 4 areas. And again, there are plenty of other areas to get involved with AI, but really we want to focus on 4. And one is the opportunities that AI presents to healthcare and potentially could offer healthcare in the future. Second is about the challenge associated with the data. As Matthew said earlier, garbage in, garbage out. How could the use of data potentially increase the bias of the outcome? And then the third will be other types of challenges facing healthcare using AI. And then the final one will be, what are the recommendations that we have for the federal government in the area of AI? Where should the regulatory arm of the government step in to regulate this area of healthcare? So with that, we will move to our first section, which is on the opportunities. And I think we can skip to the next one. And with that, I'm really pleased to introduce Chris Khoury from the American Medical Association, who will walk us through some of the potential opportunities associated with AI. Welcome, Chris.
Thanks, Rob. Thanks to the WEDI team for organizing this, and glad to be here today. And also special thanks to Rebecca. I really enjoyed getting the patient's point of view there. And I was just mentally drawing a lot of connections in my head to the other side of that coin, which are physicians and providers, and just how important the human interaction component is. I think that's very consistent with everything we know about where physicians are trying to get back to through our various technological evolutions, the interaction, the trust, the augmentation. And so I was just really pleased to see that there is such great alignment there in the survey findings too. So as Rob said, we wanted to cover these different topics. The first one is really looking at AI in clinical care. Your contributions here are really the important part in the chat or raising your hand. You can see a number of lists of things there. I think you can really look at these as potentials, as what ifs that can happen as an outcome of our new world of AI. I would encourage us to ask questions here on each one of these. The potential to assist physicians and improve patient care, real-time clinical decision-making, that ability to self-correct over time with new learning and evolved judgment, and that important dimension of human judgment there, whether replace is is accurate here or augmentation in another scenario. And again, the potential for prediction of disease, not only prediction, but retrospective analysis of prior conditions existed in the medical record to uncover prior misdiagnosis and otherwise. Patient communication, there's a lot in there from follow-up medication guidance, reminders, and so on. I think I'll just sort of wrap up the next slide. I see a couple hands raised, and maybe I'll just cover the next slide and then we can begin to invite folks' comments. In addition to the clinical dimensions, the applications that are deployed could be through cloud architecture, could be locally deployed, but the real power here is the opportunity to simplify administrative workflows. What could that mean? Certainly billing applications, prior authorization burdens that hit providers, but also process and quality improvement initiatives that require looking at large sets of data over a long period of time, looking for patterns for improvement. And let's not also forget about education opportunities for physicians and other providers in the moment as they are providing care. And also things like credentialing, some of those other administrative burdens and workflows that take up a lot of time in medical practice and in clinical settings today. Ultimately, burnout is a really big issue. So any of these things we would hope has the potential to reduce the onset of burnout among anyone in a clinical environment. And we hope a big opportunity there. Let me pause. I see at least one hand raised. And Rob, I don't know if you want to moderate some of the Q&A.
Yeah, I think Michael's gonna, I think Janice is unmuted. Welcome, Janice.
Hi, this is Janice Karen from the Massachusetts Health Data Consortium. I think there's actually a missing step on the provider side before we talk about the things that you're talking about on this slide, and that is an educational / sense of understanding of how much providers understand AI, that it's inherently probabilistic, that there's probably some threshold level that's been set, especially if we're talking about machine learning related things, that what they're not getting when they see a yes or no or a different answer of test this person, don't test this person, or this person has cancer, this person doesn't have cancer, they're not getting an actual yes or no. They're getting, someone has said that if the answer is 80% likely, then that's a yes. And I think that the biggest problem that we have right now is that there are lots of people using these tools who have no understanding of that whatsoever, or no idea of, well, I would like to set the threshold for this particular thing to 95% because I think it's better to have false negatives than false positives. And I know you said to keep it short, so I'm going to shut up now.
Great question. Thoughts, Chris, on that?
Yeah, I wasn't sure if you wanted to continue or not. Just to say, Janice, yes, really great point around the fact that these tools at this point cannot replace clinical decision-making, should not replace them, but a chance to augment it. And that nuanced point around probabilistic outcomes and what these algorithms may recommend, it's important to take that into account, that some of these thresholds are set based on, could be commercial considerations or other kind of safety considerations that may be distinct from the clinical need and should never replace that kind of judgment that exists today by experienced professionals.
This is Kevin Larson. Also want to weigh in here. And understand that this is also important for providers to have the transparency to know what the data that this was trained on, because the same algorithm is going to perform differently based on the data that it is exposed to. So if you're on only Medicare data where everybody's over age 65, it may feel like, oh, this really works. But if your patients aren't all over 65, we don't really know how that algorithm is actually going to work on this younger population. So agree, we need both the training of providers, but also the kind of visibility and transparency tools, so we can understand as providers, here's who this was trained on, and here's the population that we really know how it performs. And if you want to use another population, here's the best information we have.
Yeah, excellent point. And I guess a question to both you and Chris is there a role for the government here in terms of should they be requiring education for physicians and other clinicians? Should there be some inclusion in medical school training? Because as you say, Dr. Larson, it's so critical that they understand how they're using this tool. Is there any role for the government to play here, or is it strictly a private sector issue?
Well, so ONC has proposed that there be what they call, quote unquote, a nutrition label that would be applied to this kind of AI that goes into providers for clinical decision makings. I think it's called CDI, clinical decision information, or CDSI, clinical decision support intervention. And those CDSIs they propose have a consistent way that they're labeled. And you might think of this like a table 1 from a journal article. Here's the population, here's what we know, here's who's included, here's who's not. They list some additional attributes. So there is already a proposal. I think it'd be interesting to hear from this group if they think that proposal is a good one. Is it adequate? What should be included?
Yeah, and Rob, just to augment that, it's worth noting that there are, I can think of at least a number of academic institutions and medical schools today that are working on exactly what you described, which is what is the content and expertise a physician of the future needs to have to be able to interpret, deploy algorithms, understand how they work. And you see other aspects of our health, our biomedical research and innovation system stepping up, including the publishing community, of which my parent institution, JAMA, Journal of the American Medical Association, has a lot of content, as do many of the other journals right now that are really helping physicians and other professionals go down the learning curve.
I like the idea of that warning label, or what Dr. Larson calls a nutrition label. But we all know about alert fatigue as well in the physician community. So it's got to be done right, and it's got to be done well. We've got a couple more hands. We'll go first to Stanley and then Stephanie.
Thanks,
Welcome,
Rob.
Stanley.
Thank you very much. Appreciate the opportunity. Sounds like another burden we are putting on physicians to learn something new that's not exactly aligned with their medical care, but another sort of technological innovation that they now have to keep on. That's a tough one. I also wanted to ask the question: how do you handle a patient that somehow gets their hand on some artificial intelligence tools, walks into the doctor's office and say, I ran my stuff through Chat GPT and it told me that I now have kidney cancer. What are you going to do about
it? We all know about Dr. Google for sure. I've heard from clinician friends that it's not rare to find a patient walk in with a ream of paper that they have printed off the internet in terms of their condition and diagnosis. I don't know, Chris or Dr. Larson, any comments?
Well, I think we could unpack that for a while. And certainly, one can think about physicians and other providers as being lifelong learners. There is always a new set of knowledge to be acquired and learned as the science and art continues to change over the years. So there's that dimension. But certainly in the AI realm, we can get concerned in this new flavor of large language models, whether folks have talked about examples of hallucinations and of false references and things like that. We know today that ChatGPT's free, publicly available version is limited in terms of the timestamp of when it was last trained, 2022, I think. So certainly concerns there compared to a normal Google search, which has up-to-date information, whether you are getting a reliable judgment based on current medical knowledge. Those are all factors I think that we need to be thinking hard about.
Yeah, and my sense about patients getting information from some kind of AI solution, that's not that different than what we have now. They've talked to a friend, they've looked at Google, they've looked at Facebook. Part of this is us collectively as a profession understanding what are trusted sources for this and what are not, because there will emerge likely some direct to consumer solutions that have high quality, have high fidelity. You can imagine any number of organizations making those available. So again, it's going to be a nuanced problem and a nuanced solution. How do we counsel and advise patients about which things we trust, and therefore help them understand why we trust them and not or don't trust them?
Excellent discussion. Before we go to Stephanie, Janice in the chat made a very good point about the nutrition label is only the first step. You also need the recipe card that outlines the appropriate ways to use the AI, etc. So very, very important. And we did mention in the chat, Dr. Angrove says, we know that Chat GPT is more empathetic. We saw that poll result a while back, which suggested that Chat GPT was more empathetic than a physician. But as Heather says, it's charming, but not sincere. Good points. So with that, if we can unmute Stephanie, and welcome.
Sure. Thank you all so much. Hello, my name is Stephanie Fiore, and I now currently work at Elevance Health, formerly known as Anthem. So thank you so much for this conversation today. Hearing everyone's wisdom, but also wit, is just very entertaining to my health policy nerd heart. So thank you for all that. And in regards to the ONC recent decision support intervention proposals, certainly want to echo some of the comments that this would need to pair with that provider education. And also, we did a study in the past regarding what helps providers trust use of AI tools. And one of the aspects that we found was that it really matters to work with providers regarding workflow. And we don't feel that maybe at this point in time that considerations for what they're putting in the workflow of the EHRs with the information, because a EHR developer that has AI that enacts or engages or interacts with the certified health IT would have source attributes, then risk intervention management. And that, similar to how you all mentioned alert fatigue and whatnot, that just might be another sort of barrier there, because it's a lot more popping up at the providers, and how are they supposed to know how to interpret that at the point of care? And also, we saw in the past, and it wasn't finalized, but the ACA Section 1557 proposals regarding how providers are held liable for their use of AI in decision-making. Ongoing conversations are still needed, so that, of course, education so that they have the support and background, but also ongoing conversations regarding responsible use, and also like, how are we approaching modernization of medical liability, and what are the considerations depending on how much AI weighs in or not. So certainly we feel like there are lots of conversations to be had to make that information useful and actionable, and something that actually helps providers better leverage the AI. And I look forward to hearing and continuing to work with you all on these input opportunities.
Excellent comments. And, you've looked ahead a little bit to some of the challenges, and liability is absolutely on there. And as Janice says, sometimes AI flat out lies to you. So I think, the point is, and back to, I think, a point that Stanley made, it's an add-on. It can't be a replacement for what humans do, because inevitably, again, back to the data used in the engine, if the data is flawed, the output's going to be flawed, and the physicians can use it as a hint or as an aid. But I think I'm sensing we're in agreement that it shouldn't replace human judgment in these clinical areas. And so with that, I think we can, Chris, move and talk a little bit, get outside of the world of the clinical experience and really into how AI potentially can impact the business side of the physician experience.
Yeah, I touched on a few things, Rob. I'm not sure. Oh, is this, I think, a
Yes.
handoff?
No, well, I
I'd
think,
be happy to jump in.
yeah, I
Yeah.
think what we want to do is just if you don't mind, just talk a little more about, for example, there's there's a lot of discussion around, can AI generate letters, and can it take away some of the burden, the administrative burden that physicians and health plans face by auto-generating some of this information. We're already seeing it. Again, that's a huge, I think, opportunity for administrative savings.
Yeah, I mean, I'll make a quick comment, and I think hand it to comments from Danielle. Can it? Yes, absolutely. The technology is there. It's interesting to reflect on the fact that these are adversarial relationships right now that cost the health system quite a lot, and what the best way is to resolve things like prior authorization is another discussion. So, but yes, administrative burdens. Obviously, one of the big kind of killer apps, if you will, are speeding up the ability to generate clinical notes, not only transcribe them, but infer from those clinical notes things like billing and coding types of conclusions from that. So yes, lots of opportunity there on the administrative side.
Excellent. And we're going to turn it over to Daniel Lloyd from America's Health Insurance Plans. But Danielle, I wanted to thank you for your comment in the chat about the new CPT appendix code. So I don't know if you want to briefly talk about those.
Yeah, you're like, why did you put that in there? Yeah, I'm happy to, but I put it in there. It's the AMA's work, but I want to give them credit because I think it's a really good framework. It may be specifically for coding purposes, but it is a taxonomy for us to think about. I mean, I think we, this group, like who we are, we jump into the details like super fast, right? But I think stepping back, when we answering questions on AI, well, what do we mean by AI? How are we defining AI, right? And there's a difference between things that are really simple clinical algorithms, like we were talking about before, like it doesn't matter whether it was literally somebody mapped out clinical guidelines on a piece of paper or it's automated, right? It's the same thing. It's just being more efficient through using the computer, right? But that's like sort of at one end, and then at the other end, you have this notion of sort of autonomous AI, where it is not just finding data for you, but it's analyzing data for you, and maybe it's even actually giving you a suggestion of what you should be doing next, right? And so I think part of this is we have to make sure we're defining it. And part of this is we need to be thinking about solutions that don't have the one size fits all approach, but are tailored toward what level of risk are we talking about, and how is the AI being used, right? There's a difference between accidentally telling somebody to turn left instead of right when they're driving versus telling someone they have or don't have cancer, right? So this notion of sort of being right-sized or proportional to risk, I think, is a really important one. But just to talk about some of the health plan uses, and some of it overlaps a little bit with what Chris is saying, and this is by no means comprehensive, but some of it is like what Rob was saying in terms of predictive analytics, and are there particular patients that could benefit from additional services, whether that's closing care gaps, right? Or things like that, where the plan is actually giving information to the providers to help with their practice. There's also other ways that the clinical models come into play for the health plans in terms of using data and AI for research to look at sort of like disease progression and looking at, for example, what are we seeing as long COVID? What are the patterns there and the trends? There's also some of the more administrative ones, like you see here in terms of claims efficiency, or we just started to talk about prior authorization. When you think about large language models and electronic prior authorization, just using it as an example, there are services out there now that will help a physician begin their prior auth to start, sort of filling it out and writing it. But you've got to be real careful if you're using generative AI that it's not lying to you, which I think maybe it was Janice who said, right? But it's becoming part of the play there. And on the health plan side of it, some of the plans are working on systems where some of the prior auth is pre-filled in. So being able to access some of the electronic health record information already putting in, it looks like this has already been done in the step therapy, but still having that human review at the end, right? So in no way is it just sort of running on its own with no person looking at it, right? And I think that's part of where the education comes in, that, even if we have automated prior authorization approvals, right? Approvals, not denials, for some things, that doesn't mean that, that's about efficiency and trying to speed things up. It's not about removing clinicians. The clinicians were involved in the creation of the guidelines, in the applications of the guidelines within the programs, with, reviews, like you're not going to have a denial without a person reviewing it, some of those kind of things. But just as some other examples, fraud detection is another area. The consumer services used within, 800 numbers and chatbots and other ways to speed things up, and enhancing cybersecurity protections. There's also use for actuarial analyses, use for improving provider directories is another interesting one, where you're doing sort of the old checks of calling the physicians and such, but then you're also using Google search results and other things through the application of AI. The plans are also using it to some extent in their cost calculators, where consumers are going to look up, if I go get this service from this provider, what is it going to cost me, by looking at some of the historical data of what services, what the service pattern looked like in the past and how much it cost in the past, and then trying to create more accurate estimates for patients at this point. So, I think it's really interesting to see the patient responses and sort of how much they think AI is used when it's just so quickly becoming ubiquitous in, again, not necessarily the autonomous level, but some of the lighter levels in sort of every aspect of how the businesses are being run. So I think that's plenty of examples here in the health plan category, Robert.
No, that was excellent, Danielle. I do have a question for you. You mentioned something important, that is addressing gaps in care. Is it too much of a stretch to argue that this could be a tremendous benefit for the plans and providers that are in value-based care contracts?
Yeah.
Where the flow of data is going to be more efficient and frankly could even be real time, that could really advance VBC.
Yeah, I think there's sort of a combination of things coming together that could really unlock the potential in terms of, AI, I'm going to say is at its best, but, some people could have its own argument over this, but when you have the large data sources, right? So to some extent, if we are able to get something like TEFCA up and running, where there's easier, seamless interoperability, so like sort of that hand in hand with applying AI on top of it, And as Kevin was talking about, being able to move those results in through these CDSIs that are mentioned in the ONC rule, where we can get the data in one place, we can analyze it, we can send information back. Of course, all within the parameters of this being monitored, the data sources reviewed for bias, monitoring the programmatic applications, because you might not have bias in the data itself, but how you apply it, could have bias, making sure the physicians sort of know when and how to use this, right? So there's a ton of caveats with all these things, but putting a few of these things together, I think really could make major change within these value-based arrangements between health plans and providers working together, and not in that adversarial part that Dr. Corey was saying before.
Excellent point. I wanted just to read a few of the responses in the chat. Jared says, as AI content is generated and begins to proliferate in our digital environment, how will we address LLMs generating responses based on previous, what he calls hallucinations, and compounding some of the current challenges? Excellent point. And then my good friend Merrill says, in regards to your note, Danielle, about CPT Appendix S, one of the themes, recognizing and acknowledging the nuances of the term AI and the context in which the term is used. A very important point. Heather says, I feel like this comes back to general population awareness of AI, which is largely shaped by the media, as we discussed, versus the reality of how broadly AI is and will be threaded everywhere.
And I just add to that particular one, and what Congress thinks it is, right? So, I mean, this is where we have a little bit of trouble for things like prior authorization, whereas there's a push to have real-time prior authorization, but then there's pushback saying, oh my gosh, AI is run amok and it's making all the prior auth decisions. Well, that's not exactly right, and that in order to get real time, you do have to have some automation, right? You have to. And so again, it's how do you balance how much is automated, how much is the human doing, where are the checks, and how do we get to the efficiency without sacrificing consumer protections and other important aspects like that.
Yeah, I think it's important, and we'll get to this towards the end of our time, is really even folks in the AI business are calling on government oversight. So it's we understand it's the Wild West, but we also understand, I think there needs to be some guardrails. And Drew, I think, mentions it'd be helpful for the conversation if we could use more precise terms. You're absolutely right. There's a lot of terminology within the AI environment, including machine learning, predictive analytics, CDS, etc. We've lumped them together probably inappropriately, but we certainly get your point. So with that, unless there are any other comments folks wanted to make on some of the opportunities associated with AI, both the clinical side and the administrative side for both providers and health plans, I think we can move on. I think we can go to the next.
Robert, just one,
Yes.
This is Kevin Larson again. I think one key one that isn't highlighted here, but that's been being used for a long time, is actually to normalize and clean up data. So there are a lot of AI systems now that take data elements, for example, hemoglobin A1C. We have an example where there were 250 different ways that came in to an organization, and you can use AI to routinely grab that in real time and map it to something consistent and reusable. And there are a whole lot of these solutions for that data normalization that are using AI. That's now embedded very deeply in our databases and our systems, but it's really an important early step in this whole process.
Excellent point. Merrill writes, we may want to look also at how the various federal agencies define AI. I think that might be one of our comments we make, which is the federal government needs to have a standardized approach to AI, and each of the different agencies can't come up with their own siloed definition. And I think Janice reminds us the problem, though, is I doubt many laws, regulations, rules will be specific to particular types of AI. Yeah, good. Okay, so I think we can move to the next section. So we're going to talk about AI bias, and I think with that we are going to turn it over. Let me see, make sure I've got this right. To
That would mine.
Yes, I believe so. Yeah, thank you. So obviously bias is so important to the output, which is going to impact the patient. So that, if you don't mind leading the discussion here.
Yeah, absolutely. This is a topic near and dear to my heart, although I am not claiming to be an expert in by any stretch of the imagination. Love this quote: if we are to develop trustworthy AI systems, we need to consider all the factors that can chip away at the public's trust in AI. Many of these factors go beyond the technology itself to the impacts of the technology, and absolutely bias is one of those huge impacts. And I guess I just want to start off the conversation with the kind of recognition and acknowledgement that we know that bias has been baked into so many things, even pre-AI, before algorithms. It's present in our EHR data. It's built into processes within our organizations and institutions, in our policies and laws. And so I think this is a very real concern, and concern that bias kind of embedded in and or related to AI has the potential to perpetuate disparities and the bias that we already find in other places and spaces, including the data. So would love to open up this conversation, and maybe go to the next slide, because that gives us some prompts. But would love to hear what the group has to say around this topic. Again, it can be related to causing harm when that bias is baked into treatment support recommendations, even prior authorization, right? I mean, I can think of so many ways that bias could potentially cause harm. How AI can impact decisions that have a ripple effect even outside of healthcare. And then always, and I think we started the conversation, junk in, junk out. I mean, that to me is where this one always starts. So any thoughts on this from the group? Janice, I will let the powers that be unmute you. We'll go to you first.
All right. Yeah, I just want to raise some points that have already been made earlier, but it's not just the data sources. It's not just human and systemic biases. It's sort of going back to, is the nutrition card enough, or do you need the recipe card? Because if you develop an algorithm at the University of Chicago Medical School, you have a certain population, and that population is likely not the same population that's sitting in the middle of rural Montana looking for care. And while I'm not suggesting that you can't geographically transpose algorithms, you do have that, you have to be careful that the algorithms you're using are designed for treatment with the population that you plan to use it in, or the type of group. There might be other factors that are, there's all kinds of factors that make that interesting. And while that's to some extent based on the data that's used for the, based on the data sources, it's still a separate consideration.
Yeah, excellent.
Yeah. And I appreciate that. I think by shorthand, we always do the junk in, junk out, but you're right. It could be high quality data, but it's not representative. It's not appropriate. So it's such a great point. Jenny.
Thank you. One of the things that this conversation elicits in me is the recognition that bias is inherently a human problem. Machines aren't biased in the sense that, given the data they should have, given the algorithms that are appropriate, they should generate predictable and useful information with the kind of guardrails that we mentioned before and that Janice described around probability. I think we see these problems with real people making decisions in real life today, whether it's someone getting a mortgage, being admitted to schools. We have bias endemic in society. And I think the exercise of rooting out bias in AI is fundamentally an exercise in rooting out bias in people. And we might at one point in the future, not today and not tomorrow, but at some point, think about how can we use good algorithms and good AI tools to address systemic bias in people. In other words, to identify, curate the internet for better content and not have the hallucination problem that Jared mentioned. Begin to use, as we develop our understanding of AI to help us deal with the bias problem that's endemic in people, and have that as a grounding for thinking about how do we root out bias in AI. Just a thought for consideration or general comment.
Denny, I really like that. This is Kevin. We also talk about thinking about both bias and fairness. And so in sometimes you may want to correct, like bias may exist, and you may know it exists. And so to build a fair system, you may name the bias, and then you may intentionally bias it in the other direction to be fair. And those are, again, human discussions and human decisions, and we need to be able to have visibility and the right kind of people in those conversations to make those decisions.
Excellent point. Ed?
Yeah, I'd just like to suggest that there's a whole bunch of people studying health equity and social determinants of health and all the challenges related to gathering medical data in different populations. And I believe those efforts would greatly help this particular problem, and trying to merge both camps together to make sure that we're leveraging a lot of their research and resources that they're developing and improving AI.
And I'm going to turn to Danielle, and then we'll go to Arthur.
Yeah, I think that's kind of where I was starting to go, Ed, is, we're careful not to say correct for bias, but mitigate at this point, because we feel like there's a lot of steps in the road to getting to a point where we can say correct, and we're sort of way back at the beginning. And we have a fundamental infrastructure problem in order to really solve this challenge, and one that we've been putting a lot of time and thinking into in terms of being able to collect standardized demographic data. And it's not just about race, ethnicity. It is about that, but it's also about, disabled status, veteran status, military status, sexual orientation, gender identity, blah, 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 right? There's a long list of things that we should be looking at to be able to see if there are biases and disparities. And until we can sort of do this in a standardized and an interoperable fashion, it's going to be hard to solve the problem and really know where we need to put our action. So some of this is around second guessing where we think there is bias and doing some advanced work there, but also building that infrastructure. And then, as Kevin was saying, how do we monitor for potential unintended consequences, creating systems and processes there? And how do we watch not just the data, right? Again, it's not necessarily the data that's the problem, the people are involved, as you said, but it's about, how do we make policy decisions or programmatic decisions around, quote, correcting or compensating for what has happened in the past. So I think we have to talk a little bit about infrastructure in order to get to these goals.
Excellent. And before we go to Arthur, I just wanted to read a chat from Ellen, who addressed that by saying, perhaps we need to create anti-bias AI, meaning create algorithms that identify when the algorithm itself is biased. So very important. So we'll go Arthur, and then I see Zachary has his hand up next. Welcome,
Hi.
Arthur.
Thank you. I'm with Kaiser Permanente, and when we, I'm going to make 3 quick points. When we respond to such RFIs for the government, we actually often will point out that bias is necessary at some times in clinical care. And it goes back to the previous speaker in terms of when you're looking at demographics, many kinds of demographics, you will find that certain populations skew a certain way. If your algorithm does not recognize that and incorporate that, you're actually possibly going to be, not treating them to the best of your ability. So it's important that we continue to let the government understand that there are times where skewing algorithms a certain way is the appropriate way for clinical care, whether you call that bias or whether you call it, some other word. Maybe that's a better idea, to create a word, but one way or another, it's important that they recognize that. My second point is that always what happens, especially at this point in the life cycle of, and it's gone totally crazy with AI, is that what the media will do is pick up an example, and it is almost always the most extreme example. And that is what we see on the front pages. That's what everybody's talking about. And then unfortunately, that's what Congress ends up talking about as well. That's not good, as we all know. And therefore, it's really important for us to figure out, how do we counter that dialogue, which is based on extremes? And then my last point kind of goes back to something that was said really with prior auth and such. We've been doing in IT logging of data forever. So we can log what's going on with the decisions that are made by an algorithm. And it's going to be essential to do that and have ways of ensuring and monitoring that and being transparent about it so that we don't get into these extreme cases. So I think that's just basically something that is going to have to be baked in to many of these solutions.
Excellent. Appreciate that. And we'll go to Zachary next, and then we'll catch up a little bit with the chat. Welcome, Zachary.
Thanks. One thing I just wanted to mention when it comes to fairness is that a lot of the work, at least that I've seen, is focused on systems where the outcomes are clearly sort of good or bad. So for instance, if I apply for a mortgage, for me as the applicant, if I would prefer to be approved, if the system makes a mistake and approves me even though it shouldn't, that's still good for me, right? Like, so if you sort of lean on one side, it can help some people have better outcomes. But for most, not all, but a lot of healthcare, particularly like diagnostic sort of tasks, it's very important to be right. So you don't, if you're diagnosed with something you don't have, that's also bad. And so I don't know how much, I think that like applying some of the fairness techniques might be very difficult for healthcare. And so in that case, maybe, focusing more on like representation in data sets might actually be really important just because of that complexity.
Excellent points. Appreciate that. And just to catch up with the chat a little bit, in response to Denny's comments, Matthew reminds us that the policymakers are seeing bias as an AI risk right now. And we have to remind them that bias is not limited to machines. I think very important. And let me see here. Heather says data is often difficult to get or itself is noisy and erroneous. Some members of marginalized communities are incentivized to lie in self-reported demographics. I think that's important to remember. Boom, boom, boom. So I think you're caught up. Oh, I want to just mention our good friend Beth says when AI is used to make or contribute to a decision that impacts a consumer, especially in an adverse way, the consumer has a right to know that AI was used and to how it was used. When consumers have this information, they can make informed decisions to object or remediate such decisions. And a thumbs up on that one. So that one, I think, is something that we might want to think about incorporating into our letter as well, really to arm the consumer. And when I say consumer, I would also include clinicians as well. They're consuming AI. And as long as everybody knows the process, the data, the biases, it's a lot easier. I think with that, I think we can, unless anyone else has a comment on this section on the issue of bias, I think we can move to our next section, which is to identify other AI challenges. And with that, I think we're going to go to Denny, if you want to help out here, walk us through a little bit of this.
Certainly. Let me bring up my video here. There we go. My name is Denny Brennan. I am, in addition to being a member of the WEDI Board of Directors, I'm the Executive Director of the Massachusetts Health Data Consortium. It's a pleasure to be here. Healthcare delivery is really often at the heart of the conversations we have about the application of AI. Many people who are only passingly familiar with AI, whether they're policymakers, consumers, technology, or business executives, often look at the delivery of healthcare as being where the impact of AI will be most keenly felt, whether for good or for bad. Among the AI challenges that we identify in healthcare delivery and that we want to talk about today with the group are, one, the cost. Does AI create added costs or does it reduce costs? And if so, in either direction, what does that mean? And how might that influence our response to this particular RFI? The second is integration issues. People are reluctant to adopt technologies if they see them being associated with job loss, whether for themselves or others. How do we deal with the integration of technologies when people's jobs are at stake and the success of an organization may be at risk in fashions that we don't understand? Trust issues, we've touched on that some with respect to bias, but we also need to look at trust that people have in what the AI is doing and how well it is doing what it's supposed to do. Fourthly, how do we manage data privacy and security when we have artificial intelligence or its various manifestations, be they machine learning or large language models or other aspects of AI application that we're not possibly complicating or magnifying violations of privacy and security? We can imagine, for example, an errant algorithm releasing data on hundreds of thousands or tens of millions of people because of a simple programming error. How do we talk about that and deal with that potential challenge? Fifth, the lack of interoperability, or the risk of a lack of interoperability among and between different AI solutions. Are they designed to work with each other? Are they going to produce discrepant and conflicting results, or the kinds of recommendations that might cause people to do things that are uncooperative or misguided? Sixth, the need for continuous incorporation of data. We saw in the chat a reference to stale data. all we have to do is look at the internet periodically to realize how stale a lot of the information we pull up in our Google searches is. How do we know that we're continuously incorporating new and hopefully better data to deal with the challenges that have been talked about to some degree already, with data being inaccurate, incomplete, or stale and no longer of any use? And finally, we live in kind of a Wild West environment. The open nature of OpenAI and the ChatGPT models are a license for innovation, but they're also can create considerable confusion among users of AI when you are faced with dozens of tools that use or bolt on to ChatGPT and other applications that erode our confidence and possibly the security and safety and privacy of the data that we use when the initial data or the initial algorithm is compounded in its complexity and its difficulty in rooting out troubles by other added services that are AI related. This Wild West environment creating, a proliferation of AI add-ons, AI applications that may be less reliable and more biased than what we have before. So those are some of the issues that we at WEDI have identified as a basis for conversation. So why don't we take a look at what we have, for example, on our chat. And I'm going to go back to, let's see. Arthur says, when AI is used to make or contribute to a decision that impacts a consumer, especially in an adverse way, the consumer has a right to know that AI was used and how it was used. Arthur agrees with this statement. However, it's becoming harder and harder to separate AI use. For instance, is it being embedded in many types of diagnostics, such as CAT, radiology? Would we let every patient know that AI is being used as part of the analysis of these diagnostics? If so, what if they want to know how it impacted them? And that was endorsed also by Heather. So perhaps we can open up that for conversation. I know Heather agreed. Why don't we get some comment from folks online if anyone has a comment to address in that regard?
And it does raise the issue of do we need a consumer AI Bill of Rights? And is it a notice in the physician's office, just like the privacy notice? Here's how we use AI in the care treatment process. I see Heather's got her hand raised. Michael, if you can unmute her. And Heather, thank you for your excellent comments in the chat. Appreciate it.
Yes, my copious comments. Yeah, so I mean, I think we've touched on this issue a couple of times that, yeah, consumers absolutely need to know, and there needs to be something like a Bill of Rights and something like a nutrition label and all these things, but there's so many touch points for AI. So I think what I would encourage us or encourage regulators to look at is, can we define, sort of a bright line of some sort that separates, here are the uses of AI that really need to be surfaced to the consumer, and here are the ones that really are okay to leave far in the background, because they're like not so relevant, or they don't have negative impact, or don't have disparate impact, things like that, right? Like, how can we, can we have a clear standard that separates those so that we can know which ones fall into which bin? Because if we end up with a regulation that says service all of them, it's going to not be useful to us. It's not going to be useful to the consumers. It will throw too much information at too many people, and it won't be helpful to anybody.
Excellent. Appreciate that. And
Robert, Beth has an excellent comment in the chat. Do you want to address that?
Yeah. So Beth says AI can scrape, search, aggregate, and learn data from the internet about you. And you can see the potential dangers around that. So at risk is not only protected health information and financial information, but also issues of national security. And that is certainly an issue brought up in the RFI in other sections. So you're spot on with that. You can imagine an algorithm that searches out all your birth dates and your children's names and is able to try different password attempts. So yeah, very important. And then I see Don's got his hand up. We'll go to him in a second, Michael. And a good point here. Notice in the office will not enable patient consumer awareness in indirect situations. No question about that. And I think that is a general issue that we may want to raise in our response, which is everybody from clinicians, health plans, vendors, and consumers need to be educated on this. I think that's the message that I'm hearing. And Sonia says a patient's bill of rights regarding AI is a good idea, like the HIPAA form to be used when receiving service. So at least patients are used to getting these forms. No guarantee they will read them, but at least they may receive them. And Heather has to drop, but thank you again for that. And with that, Don, welcome.
Hey, Rob. A few thoughts. I think I really enjoyed this conversation. I think it's been one of the best ones I've been to in a long time. I think there are a lot of issues floating around, but it really reminds me of the evolution of the electronic health record. And the definitions piece really became clear when the government role became certifying electronic health records. And I feel like some similar effort should be done here so that you can understand what it is. And that they're following the proper security guidelines and other things before it gets adopted. And then I really feel like it's a tool that once providers, and I'm mostly focusing on the patient care aspect, once the providers start using it, it will become more trusted. But I think that there ought to be certain policies and procedures that are followed to make sure that the content is curated and also that it's giving that it has the full picture before it gives any opinion on anything. So meaning if your record that you send into that AI input doesn't have all the information that it needs, it should be able to respond back rather than giving a wild guess. So that's where I think the curation really is something that should be monitored. And just like there is a complaint section on CMS website, or there ought to be a way to report that a provider feels like they expected a very different result. And if that gets out of control, it could lead to, is this AI company really focusing on keeping this content up to date? Have they addressed this particular bias issue? And, because I really feel like no matter how you try to avoid it, you're going to find that there are people who rely on it too much. A lot like, I had to parallel park a car when I was a young person back in the day. And now you can press a button. So, I don't know if it works, but I understand that some of that car technology doesn't work. We know that the airline technology didn't work. And so it's one of those things where I don't want to be the one on the operating room table, just as they're putting the mask on and they say, now everybody check the AI, see what it says to do to Don. So I feel like, it would just really add a lot of trust into this particular type of work, but that's my comments.
Excellent.
Thanks again.
Before we go to Danny, I just wanted to capture those two, I think, really great suggestions, Don. One is that we encourage ONC to bake into their EHR certification program this AI to make sure it's being handled in the right way, that there are appropriate security measures in place. And the second is, much like they have on the HIPAA privacy and security side, they have a complaint process. And maybe we need one for clinicians and one for consumers. So get some feedback from both groups. Denny, start.
I'm nodding.
Yeah, hey,
I'm nodding along with you too,
Oh.
Rob. I think you brought up an interesting point. So we'll go from there. I had another one to add, but I forgot what it was. You were so interesting.
Hey, it's Kevin Larson, just to jump in here. So I was at ONC when we made those definitions of EHR. The FDA is also an important player here. And so the FDA has typically regulated software as a medical device. And, think of things like pacemakers, where there's long been complicated algorithms embedded within technology that is automated. And so that's the kind of frame that the FDA has used in the past for regulation. FDA put out a letter last fall with kind of some guidance about what they're thinking and how this might work. One thing I'll highlight is that for those of us developing AI in clinical situations, we want to do, Don, what you've described, but we don't yet have clarity between the various government agencies, between FDA and FDAC and ONC about just what exactly are we talking about, who's going to regulate and in which way. And so we're continuing to move forward and really want to lean into that regulation, but also want to be sure that that we can get as much visibility into what's coming so we can make the kind of business decisions and business investments that we believe are important in this space.
Kevin, I think those are good points. And I'd just like to add that I think if we have the right framework, we can address these bias issues and these, health equity issues as they are investigated, as they're uncovered. I don't think they're going to be all uncovered by Tuesday and we just bake them in Wednesday's release, right? So I feel like, we can kill two birds with one stone, so to speak. Oh, heal two birds with one stone. That sounds better, right?
All right. We'll go to Denny, and then we've got a couple last points, and then we'll move to our last section. Denny?
Just briefly, I wanted to second Don's comment. We've seen with privacy and security that an attestation model doesn't work. And obviously that's a much more complicated human and technology driven problem. But we know that people who have attested to, complying with NIST, other security and privacy frameworks have still been, unfortunately, victims or, perpetrators, however, unintentionally, of big data breaches. So I think, one thing we might want to consider in our response is, recommending that the appropriate government agencies adopt the certification model, as Don was describing, one where there is, something that can be as close to a stamp of approval, however that evolves over time, because an attestation model that your algorithm is not biased or that your model is trained on good data, it just comes with the risks of failure are so high. I think we need to look at that carefully.
Excellent. And I'm going to bleed into our next section a little bit, but what I'm hearing in the comments and in the chat is that there's a need for some sort of centralization of whether it be definitions or government action, because we can't have all of these different agencies that have some fingerprints on AI come up with different strategies, different definitions. So I think that may be one of our recommendations, is they create sort of a central office that can really coordinate all of the different government agencies. And there may be an office of AI in HHS to coordinate on healthcare specific issues as well. So we're going to give the last word to Zachary on this, and then we're going to move to our next section. Welcome.
Yeah, thanks. Denny's comments about the, I guess, like NIST and security brought up something that I do think there's an issue with models where it's it's not necessarily that prescriptive, and there's sort of you check all the boxes and yet you're still very vulnerable without knowing it. It's a real issue in security, and I don't think it's something that we want to replicate in AI. And yet I think some of at least what I've read about how the FDA is thinking about approaching, software as a medical device, is around sort of like organization level evaluations of like whether or not you have rigor in how you create your products and test them. But so to me, I think at least a way to regulate or bring some safety into how things are, the sorts of solutions that are currently hitting the market that are out there, not a doctor chatbot, right? But just the sort of things that I work on, that my company, is putting out, and other similar vendors. It's there are ways to test them. There's many different ways that different people use, right? And you see some quantitative results that get put in marketing material, things like that. But if there was at least sort of a standardization of how to evaluate those results, or some sort of way of having, some third-party audit of some results, that then there's certain things you have to publish about, the quality of data, about, what was used as the validation. I think that would be really, really helpful for both driving better behavior and making it easier as an end consumer, at least like if for the hospital that's buying the system, for the physician that's going to potentially use it, to look at something and say like, okay, I know what they mean, right? When they say accuracy, I know what I should expect out of this system. And I know that the numbers they're giving me at least have been somewhat verified, rather than just, something that was in like a sales brochure.
Appreciate that. Excellent. I think with that, we can move to our last section. And of course, we've already started to talk in this area, but I'm going to turn the floor over to Dr. Larson with his past life experience with HHS and ONC. He has a unique perspective on this.
Hey, great to be here. So we've highlighted this, but again, to just delineate it a little bit more. So there is work happening across the federal government, and this webinar is entitled "A Response to the White House's Proposal or Request for Information around AI." So NIST, they do standards across government and across the country, across industries. So they have put out an AI risk management framework. There is a blueprint for an AI Bill of Rights. And then there are some existing laws and regulations that apply to AI, and some of these are from FTC, some of these are from FDA in the healthcare space. So the question is, there may be more that is needed, and AI is likely having impact much faster than government can regulate. So a quick example there, my 19-year-old nephew is doing a summer internship with a marketing company, and he's using a large language model every day to create the marketing materials for this company. They've not been in wide use very long, and already we have them in the hands of a 19-year-old high school graduate, putting them out on the web. So the questions here, I think, are wide open, and would really love to hear comments and feedback. There are, specific rules on the HT rule from ONC, as well as the request for information from the White House. But many of these government agencies are now looking for our input. Thoughts here?
Well, I will tell you that here at WEDI, we actually use ChatGPT to generate a marketing piece sort of as a test. And it was remarkable in how accurate and well done it was. So I think your nephew is, I think this is going to be very typical of what organizations do. I will say we've got some really good comments in the chat. Let me just grab a little bit here. So we've got Sonia. Go
Yeah,
ahead.
Sonia has suggested a new cabinet level agency to coordinate AI across all the branches of the federal government. I think it's a really interesting idea. I think there are some industry specific concerns. There are some risk-based strategies that may be different in healthcare than there are in marketing, for example. The next question is, or the next comment is that the National Academy of Medicine has just launched a new initiative on healthcare AI. So there's a link to that initiative, and it is just getting started. And there also, from Janice, there's a lot of intersection between data use privacy regulations and AI. In fact, last year, the FTC released an RFI for data privacy that had a lot of focus on AI. We've also been hearing from Europe a number of potential additions to their privacy laws around the use of data in AI. So there is both which data can be used and how can it be used, and then there's also what are the appropriate uses and what's the appropriate governance and oversight and testing both internally and externally when AI is used for various functions.
So let's open it up. So now we're at the stage we've seen some of the opportunities. We've also talked about some of the challenges. If we could have our magic wand and have the government take action, here's our opportunity to say, here's where they should take action. We've got some specific things around, for example, ONC and maybe FDA. Other areas of AI that we feel the government should be addressing. Anything that comes to mind? We've got here some, Arthur writes, agree that it's essential that different arms of the government align themselves. My concern is that Congress and the states may jump in too quickly and create laws which will be difficult to manage as a whole. And especially, you want to balance oversight with not stifling innovation as well. I think that's important. And he also mentioned some states have already begun to pass laws, and many of them have laws that they're debating. So again, this is a burgeoning area for regulation. Janice says data use consent rules from individuals contributing data to commercially developed AI. I like that idea as an area of oversight for the feds.
Yeah,
Yep,
I think an initial consideration here is it's one thing to set out a regulation, a policy, or a law. It's another thing to be sure we have the right kind of oversight and the right kind of infrastructure to monitor, audit, and test that people are following that law. And so I think, in addition to recommendations to the government about here's what the regulation should say, one of my questions is who's going to actually enforce it? Who's going to build the support for it? Who's going to help us understand what you mean? Who's going to help us through any kind of oversight or regulatory process? Because that's where the devil's in the details. Any of you that have worked to get a software as medical device approval know that it is not straightforward to know what you need to do to make that happen.
Yeah, and Arthur agrees absolutely, Kevin, regarding enforcement and infrastructure to monitor laws. And we've got
yeah, I'd personally love to see not just enforcement but support, right? All of us know this is going to happen, and if the only thing we have is an enforcement arm, then we all get into either avoidance of regulation, or how do we get around regulation, or how do we, stay under the radar. We want this to be safe. We want this to be effective. We want this to be fair. How do we build a national system that helps all of us in technology achieve those things? That is about collective learning. It's about support. It's about sharing. maybe an example there is the Federal Aviation's Commission National Safety Board, where all of the airlines share data together and they all look at what were the issues. And that's not to be punitive. It's really to say we want all the airlines to be as safe as possible. And so the best way to do that is to have a safe third party where we can share our near misses, share our issues, and collectively build solutions. It would be really cool to have something like that in this space so that it's not I'm not afraid of the government regulation. Instead, I say, hey, here's a terrific space. I can get better, and we can collectively get better.
And Dr. Larson, Matthew asks, should there be a new agency? I mean, that's quite the step to create a new agency. But is this the type of technology that warrants that type of action, or can we work within the existing agency structure?
Yeah, I think there are a couple of questions here. One is about regulatory authority, and then another is about, who's resourced to do this, both from enough money and enough people. So regulatory authority, for example, all of the ONC certification is voluntary. It does not have any certification that is mandatory for any kind of technology. It's all voluntary. Why do the EHRs do it? It's because of the CMS EHR incentive program that they get certified. So lots of health technology doesn't go through certification through ONC because it doesn't fall into those CMS rules. Additionally, there are many agencies that have done regulation that have very few people. There's very few people there for technical support. There's very little dollars for either enforcement or for technical support. So the two things I think before you just say a new agency, we have to first say, what's the authority we want it to do? Is this audit? Is this regulation? Is this support? Is it some combination of all of those things? And if it is some combination, who has it already? And if there are holes in it, what do we propose? What do we recommend to fill those holes? And then secondarily, what's enough resource, both of the right kind of human expertise and money, to actually be able to do this at a national scale? And so those would be the questions I would really ask and give suggestions about what our solution is, rather than just say a new agency, because they could appoint 3 people and it could have no authority, and then they just go around giving speeches.
Yeah, no, excellent point. Ed makes I think a great suggestion, and that is for us in our comment letter, maybe to remind the government that there are AI solutions that what he call are mission critical, and then there are others that are candidly less critical. So be able to discern those and really make sure there's oversight over the critical ones. I think that's a very good point to make. Jeff says, Kevin, you make some great points. The idea of clear and implementable government regulations are tremendously important. Given the different risks across different domains, perhaps the structure is a White House level office that oversees AI being implemented in each different department and agency that regulates. So I like that idea about having sort of an overarching cabinet level position, because AI is impacting every single sector of the US economy, not just healthcare, but there also has to be recognition that healthcare's AI concerns, needs, and opportunities are different, and maybe there needs to be an office within HHS, or at least some way to coordinate the various healthcare specific agencies. And with that, I think we have come up to the end of or close to the end of our time. So I wanted to offer up a last opportunity for folks, whether they be facilitators or attendees, to make any last comments before we talk about next steps. And good point from Janice, healthcare related AI is not going to all fall under HHS, of course, yeah, FTC is not under HHS as well. So good point there. And again, maybe the point is there may have to be interdepartmental coordination efforts as well, because we certainly don't want, whether it be commerce and healthcare to have different definitions and all those things. So good point. And I think that's something that we can raise in our comment letter. I'm going to put Ed on the spot, just give him an opportunity to say any last words before we close out the event.
Well, Rob, thank you. I appreciate everyone's interactions. The talent and the knowledge here has been very impressive, and conversations have been great. The chat was lit up, and I appreciate all those who offered their opinions. So well done, everybody.
I appreciate that, Ed. And I can assure you that I will be using ChatGPT to write the comment letter. So hopefully it'll turn out well. But in all seriousness, I did want to thank a few folks. I wanted to thank our board chair, Ed Hafner, our vice chair, Matthew Albright, our board member, Denny Brennan, and also Dr. Rebecca Ongrove, Chris Curry, Dr. Kevin Larson, and Daniel Lloyd. Wonderful discussion. A special thanks, as always, to Michael McNutt for his wonderful work. We've got a couple of last slides. I wanted just to see if folks are interested in WEDI doing more in the area of AI. I will remind you, Ed had a wonderful 3-part series on AI through his emerging tech work group. All of those presentations are available free of charge to WEDI members, so take advantage of that. So we're seeing here, I think, a clear interest in this area. So keep watching WEDI in the next few months. We'll put together more educational sessions on this. I think we can close the poll. And then if you go to the next slide, Michael. So I wanted just to invite everybody. It's not AI specific, but we are going to talk about the prior auth proposed regulation, and one never knows, it could be finalized before our event in August, but we'll spend one day discussing prior auth and the second on electronic attachments and potentially some other issues. So it's a live event with a virtual option. So I would encourage all of you to join us in Chicago. And with that, I think we can close the event. Again, thank you, Michael, for your great work behind the scenes. And thank you all for participating in this member position advisory event. It's members like you that make WEDI so successful. So with that, I'll close the event and wish you all a great day.
Thanks all.